Our next presenter is Jenny Hahn, who's one of our pulmonary critical care attendings based at Grady. She'll be speaking about medical critical care, a year in review.
Good morning, everybody. It's so great to see so many familiar faces in the audience. So these next series of talks is meant to highlight some of the more significant, high-yield articles that have been published within the last year. So for my research, I went ahead and looked at about 7 journals, and I reviewed all the literature that was published over 2015 up until February 2016, and I basically picked my favorites. So I'm going to discuss the articles, and I'm going to critique them, give them my interpretation of where some of their limitations may be, and then we're going to go ahead and interpret them to see how that applies to our patient population. Now, Dr. Cooper-Smith did a wonderful talk on sepsis yesterday, so I won't be reviewing the second article that is listed in your handouts. That will give us more time for the others. But I had to start with the first article that assassins SIRS. So this was the study, as Dr. Cooper-Smith mentioned yesterday, that there was a consensus of expert opinion of the SIRS criteria without any clear evidence-based research to support it. So these investigators looked at specifically the hypothesis that they thought that 2 or more SIRS would have low phase construct validity to actually to increase risk of death. So they went ahead and they did a retrospective study over 14 years worth of data in all ICU admissions in Australia and New Zealand. Now, this database is prospectively collected as part of their quality assurance program. So their primary outcome was in-hospital mortality. So they divided their data sets into SIRS positive severe sepsis patients, so 2 or more SIRS criteria with infection, organ failure, or shock, versus who they defined as SIRS negative severe sepsis, so SIRS less than 2. They had a very elaborate statistical plan, as you can imagine. There's multiple variables that you want to try to account for in such a large study. And so they use a fancy statistical method called least absolute shrinkage and selection operator method to create a multivariable model. So what they found was significant in the sense that if you had 2 or more SIRS criteria, you did indeed have a higher rate of mortality that was unadjusted, but the severe positive patients parallel the SIRS negative patients in a linear fashion. But then when you adjust it for the severity of illness, now in Australia and New Zealand, they use a different severity model, somewhat similar to our Apache 3 scoring system. They found that mortality difference actually was actually matched. Now, they also found that if you increase the risk of each SIRS criteria, you're at a higher risk of mortality overall, and this was in a very stepwise linear fashion. So the authors concluded that, again, the SIRS criteria rule missed 1 in 8 patients with severe sepsis. So think about that. That's actually a large patient population in our ICU that we are missing. They also decided that each additional SIRS criteria would increase the mortality in a linear fashion. The most common SIRS criteria was heart rate and respiratory rate. And that this is really what put the nail in the coffin. They found that 2 SIRS criteria did not define any specific transition point of risk. So SIRS criteria, rest in peace. So this is 14 years worth of data. So this is a very robust study, in my opinion. And it's also great because the data was prospectively collected. But the caveat is this. They collected data within the first 24 hours of ICU admission. So one could argue perhaps the SIRS criteria is more sensitive for a patient who's been in the unit for several days or weeks, whatnot. Now, my guess would be probably not, but again, those are one of the things to consider. So the next article I want to discuss are for my proceduralists and my nurses in the audience. So this was a study that was published in September looking at the incidence of major complication of thrombosis or bloodstream infection depending on the insertion site of your central venous catheters. And so there was a randomized controlled trial in 10 ICUs in France, and they elected all adult patients that at least had 2 sites available, so subclavian, jugular, or femoral. And if you had all 3 sites available, you're randomized to one of those 3 sites. However, if you only had 2 sites available, you had a 2-choice scheme. They stratify these patients according to the ICU, use of antibiotics versus no use of antibiotics. And they
had qualified experiential proceduralists, which they defined as people who have placed at least 50 lines, whether it be a house staff or a physician. They did the same techniques that we do in our ICUs. There were maximal barrier precautions. They used cylinder technique. What is interesting to note here that they did not use their triple lumen catheters for routine blood sampling, as many of us do in our units, nor do they use their lines for renal replacement therapy. Now, their method was if the catheter was removed, they would send the tip for culture and they would have a consequent peripheral blood draw. If they're discharged from the ICU with a line, they would then again do blood cultures from the line and do a peripheral blood draw. Within 2 days of catheter removal, they would do an ultrasound at the site to see if there was any evidence of DVT. Their primary outcome was whether or not there was a major complication-related risk, which again they defined as bloodstream infection or DVT after 48 hours after removal. Their secondary outcome was just colonization from the line or symptomatic and asymptomatic DVTs. So this just shows us a very robust study. They screened about 7,500 patients. They enrolled about 3,400 patients, and about 2,500 underwent the 1-to-1-to-1, the 3 different sites, and about 900 underwent the 2 assignments. They were very good about collecting who had which sites that were not available and then comparing head-to-head the other sites. So the results, they found that anatomical landmarks were used most frequently for subclavian and femoral lines compared to the jugular. As you can imagine, femoral lines were inserted more quickly. The average use was 5 days of catheter use. Now, what's interesting to highlight here is that the subclavian group had a higher rate of mechanical complications, which meant pneumothorax requiring a chest tube. That was statistically significant. But as you can see, the femoral line group had a higher percentage of symptomatic DVTs, and the subclavian had the lowest percentage of bloodstream infection. And when we went ahead and looked at between femoral and subclavian, again, the femoral lines had a higher rate of bloodstream infection and symptomatic DVT compared to subclavian. And with the femoral versus jugular, there was a higher rate, again, of symptomatic DVTs. When they looked at asymptomatic DVTs, again, there was a much higher rate in the femoral group compared to the subclavian group, and the major complication, mechanical complication, the subclavian group. And there's also a higher risk of jugular, again, of DVTs compared to the subclavian group as well. So when we looked at the insertion rate failure, there was a higher rate of insertion rate failure in the subclavian group, but it actually mirrors the fact that most of these patients had anatomically placed landmark subclavian lines. So 85% of these patients did not use ultrasound guided. So the authors conclude from this study that subclavian site has lower risk of bloodstream infection. They have a lower risk of DVT, but the cost is a higher rate of pneumothorax. They also concluded they agree with the CDC guidelines that recommend subclavian site to be the preferred site in adult patients. Now, this is a very large study, and they captured great clinical data. What I think is important about this study is that it highlights the high incidence of asymptomatic and symptomatic DVTs, which I don't think is something that we really think about often in our central lines. What's likely missing also is that they didn't do an ultrasound on patients that were transferred to the floor with a central line in place. Therefore, we're probably even missing more asymptomatic DVTs from line placements. Again, this highlights the importance of ultrasound guided. So obviously, the high mechanical risk can be mitigated by using ultrasound guided subclavian use. However, for those of you who do ultrasound guided subclavian, it is a markedly different technique than the landmark insertion for subclavian. So there's an educational piece, and there has to be training and expertise that needs to catch up to minimize the risk of mechanical complication. So with that, I'm going to do, this is for my respiratory therapists out there. When's the last time there's been a vent trial? It's been forever. So this is a randomized controlled trial looking at adaptive support ventilation versus pressure control. Those of you who are not as familiar with ASV, it's not used commonly through all our ICUs at Emory Healthcare System. It's an algorithm based looking at respiratory rate and tidal volume to minimize the work of breathing. And so if you're a passive breathing patient, it's in a pressure control mode, but if you're a spontaneously breathing patient, it ends up being a pressure support mode. So the same authors and investigators of this study had recently published a trial looking at ASV during the weaning phase for COPD exacerbated patients. And they found that it actually decreased the weaning time. So they then wanted to hypothesize that ASV modality could actually shorten the total mechanical ventilation duration when compared to conventional ventilation. So this study was done in a 29-bed Turkish prison. No, I'm just kidding. Make sure you guys are still paying attention. 29-bed ICU that specialized in pulmonary diseases and thoracic surgery patients. So they enrolled anybody who was ventilated, but excluded ARDS patients. So they randomized it to either ASV versus pressure control, and very standard kind of modalities that we tend to use. They did the same sort of sedation, vacation, spontaneous weaning trials. They're very protocolized on how they would adjust the ventilator. If any patient failed to wean after 10 days, they were trached. And they defined weaning success as independence from the ventilator for 48 hours. They wanted to prove that there was a 3-day reduction in mechanical ventilation days, and that required 112 patients per group, which they met. And they found in the results that they did indeed decrease the time to weaning, the time during weaning, which then meant there was a decrease in total mechanical ventilation duration. And even though the hours of weaning duration were the same, as you can tell, the interquartile range was so variable in the pressure control group. This is what caused it to be significant. And what's interesting is they also looked at total number of manual settings per patient, which was actually also significant. So there was less intervention that needed to be happening to the vent. There was no change in length of stay in the ICU or intubated free days. So the author concluded that ASV shortened the total mechanical ventilation time and weaning duration with fewer number of manual settings. Now, we have to take our caveats. They excluded ARDS patients and potentially very sick, complicated pulmonary patients. Most of their patients, again, were these COPD patients in a thoracic unit. So there are a lot of COPD exacerbations who were probably on light sedation, who just needed a couple days of rest before they were successfully extubated. But I think this is a very good modality to consider in your post-op patients, which is kind of where we tend to see ASV used most often in the SICUs over at Emory, and somebody who we think may not be prolonged ventilation. But to be honest, I am curious to see how this potentially could translate in the MICU complicated pulmonary patient, because it does seem to suggest some favorable results. So the last article I'm going to discuss is high-flow nasal cannula in acute hypoxemic respiratory failure. So we've been using high-flow nasal cannula therapy for a couple of years now, and the idea is that you're generating really low levels of positive pressure in the upper airways through large flow that will change the driving gas. And so this will decrease the dead space and flush out the CO2 that will decrease your work of breathing. So the hypothesis of these investigators was to see if there was any difference between high-flow nasal cannula versus non-invasive versus just regular non-rebreather mask, and whether that would reduce the rate of intubation or improve outcomes. So this was 23 ICUs in France and Belgium, and basically they really wanted just isolated hypoxemic respiratory patients. So they were randomized in a 1-to-1 fashion. They were not blinded. They had titrated to SpO2 of 92%, depending on non-rebreather, high flow, or non-invasive. They had a target tidal volume for the non-invasive. The minimal requirements were they had to be treated for 8 hours per day in each treatment group for at least 2 days. Their primary outcome was proportion of patients who would require intubation within 28 days of randomization. And they did allow non-invasive if a patient was about to be intubated. And their secondary outcome was ICU mortality, 90-day mortality, and mortality-free days. So the majority of these patients were patients with pneumonia. 75% of patients in each arm either had community-acquired pneumonia or hospital-acquired pneumonia. So a pretty select group of patients. The primary outcome was no difference in their rate of intubation. However, when they looked at survival after 28 days of randomization, there was an increased survival for patients who had high-flow nasal cannula compared to the other treatment groups. When they looked more closely at it, the high-flow nasal cannula group had a larger percentage of patients who had lower P to F ratios. The higher mortality were in the non-invasive group, in the mortality in the ICU and at 90 days, But this was also driven by the fact that there was more refractory shock in the non-invasive positive pressure ventilation group. So the authors here concluded that in patients with non-hypercapnic acute hypoxemic respiratory failure, the various treatments did not result any difference in intubation rates, but that there was a significant 90-day mortality benefit in the high-flow nasal cannula group. I think this is a great clinical question. I think we consider this a lot in how we manage our hypoxemic respiratory patients before they're intubated. I think there is a big confounding variable having refractory shock as a cause of death. However, and also maybe non-invasive, ventilation is probably not the proper treatment for isolated hypoxemic respiratory failure because they're not having ventilatory issues. So I think these two variables are a little bit confounding for this study. But for isolated hypoxemic respiratory failure, I would actually strongly consider using high-flow nasal cannula. Now, there are 4 other studies that I gave honorable mention to that are actually also free articles you can pull off of PubMed for you to review at your leisure. Thank you.